So we're still talking about the transfusions, and in this section we'll deal with the complications of transfusion. There are a lot of complications that can go with the transfusions, so let's get into complications and see what these are and how these are managed. So there's some complications that can occur from a single transfusion only. So these complications include the incompatibility hemolytic reaction. So you gave blood which was not compatible, the blood was not compatible between the donor and the recipient. Once that occurs, there would be extensive hemolytic reaction that would occur rapidly and that would deteriorate the condition of your patient. In such a condition, you should always stop the transfusion, should look for the reason as to why that hemolytic transfusion reaction has taken place. Now we can have febrile transfusion reactions. Again, that is due to the leukocytic elements in the blood. The leukocytic elements produce a host versus graft response in the recipient, and it can cause fever, febrile illness, chills. So in such a condition, you need to stop the transfusion so that your patient might not worsen. Now there can be allergic reaction to some antigenic component of the blood that might not that might be perceived as a foreign antigen by the recipient's body, and allergic reaction can occur. Then infections can occur. So there's a variety of infections that can occur. The infections can be bacterial, which are usually due to faulty storage of the blood. There can be hepatitis due to ill screening of the blood. The HIV, again due to ill screening of blood, and even malaria can be transferred as a bloodborne pathogen. Now you can cause air embolization or air embolism. You can induce an air embolism while cannulating your vein, so that can occur. That is a personal error that can occur during your procedural error that can occur during your transfusion process. Then there can be thrombophlebitis, that is inflammation in and surrounding the area of cannulation. The inflammation and infection can go into the vessel and result in inflammation, infection of the vessel itself. And finally, there can be transfusion related acute lung injury. It usually occurs from the fresh frozen plasma. So these are some of the effects or some of the complications that can result from single transfusion reactions. Now, with massive transfusion reactions, we have massive problems. Let's see what the complications are. There can be coagulopathy. We have talked about it before. The coagulopathy is due to consumption as well as dilution. So there's consumption of the clotting factors, the coagulating factors, and there is dilution of the consumption of the coagulating and the clotting factors as well. So both due to consumptive and dilutional coagulopathy can take place. Then there's hypocalcemia. Hypocalcemia develops as a complication of blood transfusion. Very important, must be remembered. The details are very extensive. I'm not going to go into details because these are covered in the metabolism, in the process of metabolism, and requires an extensive lecture on the metabolism and how the calcium metabolism goes on. Now, hyperkalemia and hypokalemia, both of which can develop due to blood transfusion. The level of potassium in the blood is kept within a very tight range, because both the hypokalemia and the hyperkalemia can cause arrhythmias in the heart. So the management of potassium content of the blood is affected by massive transfusions, because you're transfusing the blood again and again. New molecules are potassium molecules are being entering into the blood, so the body cannot sustain itself and could not maintain the sodium potassium gradient across the membranes, as a result of which either hypo or hyperkalemia can develop. Again, the details of which are very extensive and are covered in metabolism and cannot be taken up at this point in time. However, what you need to remember is hypo and hyperkalemia, both of which can develop with extensive massive transfusions, and both of them affect the heart, so they can cause arrhythmias. Now we can cause hypothermia. Hypothermia is always due to decrease. Hypothermia is due to decrease in the thermogenesis. The body cannot undergo thermogenesis due to decreased blood supply to the muscles of the body. Due to decreased thermogenesis, there is decrease in the heat that is produced within the body, as a result of which the temperature of the body falls. And finally, we can have iron overload. Iron overload is commonly seen in thalassaemic patients. This is because of extensive amounts of iron that is given along with the blood. The iron overload can be treated, or at least somewhat treated, by chelating agents. So that is something that occurs with massive transfusion as well. Now, the management of coagulopathy is very important. So correction of coagulopathy is not necessary. When is it not necessary? When there is no active bleeding and there is no active hemorrhage and the patient is not due for surgery. So if a patient is coagulopathic but stable, you do not require active management. So a stable coagulopathic patient would be a patient who's not bleeding actively and the patient who's not due for surgery and is not hemorrhaging. However, following or during a massive transfusion, coagulopathy should be anticipated and managed aggressively. We have talked about transfusion, we have talked about hemorrhage. Whenever hemorrhage occurs, there's dilutional and consumptional coagulopathy. So coagulopathy should always be anticipated and should be treated even before it has begun. Coagulopathy will always be there with the hemorrhage. So once you know that coagulopathy will be there, you should develop an algorithm so that your management always takes into account the coagulopathy, be it consumptive or be it the dilutional type. Now, fresh frozen plasma are given if coagulopathy, if the prothrombin time or the partial prothrombin time, the PTT, is more than 1.5 times normal. So this is the takeaway slide. This is a takeaway slide from this presentation. This is what you need to remember. So if PT, the prothrombin time or partial prothrombin time, the PTT, are more than 1.5 times their normal limit, what would you transfuse? You would transfuse fresh frozen plasma. However, you'll give cryoprecipitate if fibrinogen is less than 0.8 gram per liter. Now, why is that? Cryoprecipitate, we talked about it in the beginning. It is rich in fibrinogen and in factor VIII. So giving cryoprecipitate in a patient who has a fibrinogen level of less than 0.8 would correct the coagulopathy as such. So these are the patients that require cryoprecipitate. Now, you should give platelets to the patient if the platelet count is less than 50 exponent 9. So the normal limit of platelets was 2.5 to 3 exponent 9 per liter. Now, when the limit falls beyond 50, below 50, that is when you transfuse platelets to the patient. So 3 important transfusion criteria: fresh frozen plasma for PT or PTT less than more than 1.5 times. Then you give cryoprecipitate, and you give cryoprecipitate when fibrinogen is less than 0.8 grams, and you give platelets. The platelets are given when the platelet count is less than 50 exponent 9 per liter. Now, in cases of non-surgical hemorrhages were those in which you could not pinpoint the source of the hemorrhage and a diffuse crusting surface was present. The entirety of it was bleeding. Now, it takes tests and takes time to arrange. Now, non-surgical hemorrhage cannot be corrected by the correction of coagulopathy alone. You should perform the specific tests that are required to assess what exactly is wrong, and then you should correct the wrong element, the portion of the coagulation cascade that has gone wrong, that has gone rogue, so that your bleeding or your hemorrhage can be corrected. You may underestimate the degree of coagulopathy in a non-surgical hemorrhage. However, that would be your biggest mistake. What I would recommend is develop an algorithm in which you always take into account the coagulopathy that has to develop, and once you develop an algorithm in which the coagulopathy has been taken up, you would always be able to treat your hemorrhage carefully. Now, the treatment is instituted on the basis of clinical evidence of non-surgical bleeding. So, if you find a clinical evidence, however, you do not have the means to support your clinical argument, always go for a senior approval. Ask your senior, tell your findings, express yourself so that you might be wrong, but you might just save your patient. So whenever you feel like your patient is bleeding and you do not have a sufficient technique to or you do not have sufficient material to withstand with your assessment, always ask your senior, always tell your senior what you are feeling, what you are finding. Your senior might guide you in the right direction. You might be the savior of your patient. Now, moving on, there are pharmacological adjuncts that can be added to the blood component therapy. The indications and efficacy are yet to be established, so they are not very popular. The antifibrinolytics such as tranexamic acid and aprotinin are commonly used and administered. These are the pharmacological agents that might help in the management of coagulopathy. However, their efficacy is not determined yet, and they're not widely used. The recombinant factor 7A is also under investigation, however, not used throughout the there's not a lot of literature for the support of its use. Now let's talk of the blood substitutes. So this is a red blood cell that normally carries oxygen. These are the hemoglobin based carriers, which are the blood substitutes, and these are the perfluorocarbons. These are also the blood substitutes. We'll see what these are and how do they carry oxygen. So blood substitutes are an attractive alternate, and why is that? Because blood is a limited resource and it is difficult to harvest blood. Now it saves from immunological and potential infectious complications because these are non-organic these are organic materials, but they're not biological materials. So these are usually antigenic. They do not have any antigens on them, and since they are controlled and tested, so they are non-infectious and they prevent from these complications. So there are several of these that are under investigation. Now, synthetic oxygen carriers are currently the primary perfluorocarbons. These are the synthetic oxygen carriers. Here you can see this is the perfluorocarbon, which is a synthetic oxygen carrier. So there are two types: the biomimetic or abiotic. We have already talked about the abiotic, the perfluorocarbons, and then we have the biomimetic. The biomimetic substitutes, they mimic the standard oxygen carrying capacity of hemoglobin within the red blood cells and are hemoglobin based. So these are the hemoglobin based oxygen carriers, also known as HBOC, hemoglobin based oxygen carriers. Then we have the abiotic substitutes, which are the perfluorocarbons. Now, the hemoglobin is obviously a strong candidate for it because hemoglobin is a component of red blood cell that is responsible for carrying oxygen. So it is a very important runner in the blood substitute category. Now, there are various other engineered molecules that are being used under clinical trials. However, they are still not recommended by the FDA. Now, second generation perfluorocarbon emulsions are also being used in potential clinical trials, the data of which cannot be regurgitated at the moment. The data is not very sufficient, neither it is supportive. So at this point in time, we're still in the development phase, and we'll see how that goes and when these blood substitutes would be available. So this was all about this section. I hope you liked and understood it. For further such sections, keep watching sqadia.com.